Good evening, ladies and gentlemen. It's indeed an honor to introduce a doyen of intervention nephrology, Dr. Bharat Sachdeva. He needs no introduction at this forum. We all know him quite well. He is presently the medical director of intervention nephrology and dialysis at Oshner LSU Health Center at Shreveport, Louisiana. And he has multiple publications and multiple research projects to his credit. I would not say that. I would just share one experience that we all have become intervention. Most of us have joined intervention nephrology by seeing him. My first, when I met him, he was giving a talk on the topic he's speaking today, that is endovascular AV fistula. The first time he was speaking on a case report in 2016 or 17 in one of the avatar meetings. So he finished the talk. We as DM residents never knew that such a thing could happen. So I went up and asked him, is it possible that you are making endovascular AV fistula? So then he explained the things, and that in fact motivated us to join this beautiful, to do more interventions and start doing that. So without wasting much time, we would request Dr. Bharat Sachdeva, who has been a teacher since long for us, and aptly so, he was awarded the prestigious Dronacharya Award in this avatar, to please continue with his talk.
Dr. Bharat, please share your slides. Yeah, as Vineet was telling, this particular area, endovascular AV fistula, was again, I had very scant respect for that. I thought it was, it has no relevance for us. I never used to pay any attention during this session. Bharat, you can share your slide.
I will have to quit Zoom and go back in. It's wanting me to do a little quick update. Okay, I'll join back in 1 minute.
Okay. So whenever this procedure used to be shown in ASDN or in Avatar, it would look like some Star Wars stuff, which is not practicable at all. That is what I used to think. But I think we can't neglect this. We may have to be starting this in our place also. And seeing somebody, talking or demonstrating, and it's different, in a conference podium. But I think our meeting today with Bharat, I think we'll be able to get more out of him and really see that maybe a worthwhile procedure to emulate here. And the cost definitely will go less over time. Yes, Dr. Bharat.
All right. Sorry about that brief interruption. I guess the computer did an update and wanted me to redo some slides. So thank you again for this opportunity. I think it's been such a pleasure contributing and being at the Avatar meeting. I was really humbled by the recognition that I just received. And endovascular AV fistulas have really been one of those additional...
Excuse me, Bharat, can you make the screen, your presenter screen? There should be some way. I think you'll have to...
Go to this.
So top left, you slideshow, yeah.
Yeah, your slideshow is bottom down. Yeah.
Let me do it. We'll do this.
Yeah, this is easy. Yes.
All right. Is that better?
Yes, yes.
Okay. Yeah, I'm using dual screens. That splits it sometimes. So yes, again, AV fistulas have been one of the challenges. We've had multiple reports from multiple centers which have shown a very high rate of AV fistula failure after they created. The patients get frustrated, they get sent to a surgery and they come back with a fistula which is dead on arrival. And one of the main challenges has been this new intimal hyperplastic tissue that becomes a challenge in a lot of patients. And the new intimal hyperplastic tissue is caused by multiple factors. But one of the key factors is this relocation of the vein, which is called the swing site. So as you take the cephalic vein or the basilic vein and you move it from the position that it's sitting, to a position which is close to the artery, hence the word swing it to the artery and do that anastomosis. The process of moving that vein, the process or the trauma of handling the vein, the anastomosis at the arterial segment, all are potential factors that lead to propagation of this tissue at that inflow. And right at the inflow, if the flow is throttled, it leads to a failure of the fistula right at the get-go, and the maturation process is slow. So one of the tools that has been used or one of the key breakthrough with the endovascular AV fistula creation technique is that you do not move the vein, you do not mobilize the vein. The creation of the anastomosis is as less invasive as it can be beyond the access from the vein to the artery. There is no other trauma to the artery or to the vein when you create a fistula. There are some minimal requirements to create a fistula. The vein diameter has to be a certain size. So you, under ultrasound guidance, you take a needle that you pass through the cephalic vein, through the perforator, into the proximal radial artery. You leave a wire into the proximal radial artery, which is usually an 014 French wire. You take a 5 French sheet that goes over the wire into the proximal radial artery. This is all done under ultrasound, and you will leave the sheet in the radial artery. And then you take this device. There are two separate devices available. This particular device is the ellipsis device, which will then pass into the radial artery. It has a little notch that will hook on to the artery, and via thermal energy will literally fuse and burn the connection between the proximal radial artery and the perforator vein. The perforator vein has to be about 2 millimeters in diameter. The outflow veins have to be more than 2 millimeters. And as soon as you create the fistula, the junction, there is good flow into the perforator vein and hence into the, and from there into the cephalic vein. There are several benefits of this. You do this all under ultrasound, so that's one of the key benefit that the fistula is created without any incision or cut into the skin, and you have a flow which is almost instantaneous. You'll be able to see like I said, under ultrasound through the cephalic vein or the median cubital communicating vein. You will get the access into the perforating vein and down into the radial artery. As soon as the fistula is created, this is the proximal renal artery, the perforator vein, you will have flow that goes into the median cephalic vein and the median basilic vein. And the fistula is then created without any scars or cuts into the skin. So this is a picture from one of the fistulas from the Dallas group, Dr. Malwa. There is good outflow into the cephalic vein. There is good flow into the basilic vein. But there is no typical big scar that you would normally see with a transverse fistula, a brachiocephalic fistula, or a radiocephalic fistula. So what is an ideal patient? I think if you have a patient who is a good candidate for a distal radiocephalic fistula at the wrist, I think that should be the first access for this fistula. Should be a distal radiocephalic fistula for that patient. But if not, then let's say the radial artery is small or the cephalic vein is not feasible, before we create an upper arm brachiocephalic fistula, and the cephalic vein is good anatomy for a fistula, you have a good perforator vein, that would be the ideal candidate for this fistula. So there are two devices that are currently in the market, Wavelength and the Ellipsis system. The wavelength system is a little different. I'm not going to go into the detail on the wavelength system today. It does require a dual puncture of the artery and the vein. And it has undergone some modification over time. They now use a smaller French introducer system and use a distal radial artery access as well as a venous access to have two simultaneous punctures into the venous and the arterial system, and then use a energy to fuse the proximal radial or the proximal ulnar artery with the corresponding vein. The ellipsis system uses a single venous puncture, and then the procedure is done ultrasound guided. And the perforator vein is very important for both of these AV fistulas to flow, because your anastomosis is either through the perforator to the radial artery or through the deep venous system to the ulnar or radial artery. And the flow has to come up through the perforator into the cephalic and the basilic vein. Compare that to the traditional surgical fistula. A surgical incision is made, and depending upon what technique the surgeon is using, you're either using most commonly a end of the vein to the side of the artery anastomosis. There are some other techniques that have been described as well, which are end-to-end, or another technique where you actually mobilize the radial artery and do not, or the brachial artery and do not move the cephalic vein at the time of anastomosis. So since in the last 5 years, we've had multiple publications with both of these devices that have shown fairly robust outcomes with the initial phase studies, which were done as a proof of concept studies and then were used for approval of these devices. But since then, there have been multiple other studies, including some studies which have compared the outcomes of a surgically created Gratz fistula with a endovascular fistulas that have had very comparative outcomes with the performance of these fistula. So why should we consider endovascular AV fistula, besides the fact that, so in United States, I would say 99% of all the fistula that are created are all done by surgeons. So the endovascular AV technique gives the nephrologist another skill set that they have in their own toolbox to help their patients directly without having to wait for a surgeon to get the pre-op clearance. And it's a minimally invasive technique that is usually done under at the most, a brachial plexus nerve block. There are some operators that will do this technique without even a nerve block. And then we'll talk a little more about what are the nuances of that. No scarring, faster healing. The procedure time should be less than 30 minutes. Faster maturation of the AV fistula has been reported, especially if there is a single vessel outflow that we are able to get or create via diversion of flow from some of the deeper veins that can be a challenge in some of those patients. Because these fistulas are proximal radial artery fistulas, one of the key things that has been shown over the last 3-4 years is that these fistulae remain relatively lower flow compared to the brachial artery fistula. So the risk of steel and high flow complications is limited with these access. It's an outpatient vascular access procedures. It can be done in a cardiology suite, an interventional suite, or an ASC, and the patients go home the same day. So recently, there's been an update on the long-term efficacy of the ellipsis device. So this is the initial group of 107 patients that had AV fistula created using the ellipsis device. 92% of these fistulas have been used through 5 years. Some of them were cannulated as early as 12 weeks after the AV fistula was created. The functional patency is excellent, and the cumulative patency over 5 years is very good. I talked about some of the comparative studies that have come up looking at the surgical versus the percutaneous AV fistula. I talked about this study at the meeting as well. I hold Dr. Jennings in very high regards. He's an experienced veteran surgeon who's done excellent radiocephalic fistulas with 95% maturation success rates of his radiocephalic fistulas. I've met him several times and have had several discussions about this access and what are the challenges that why we have such a high percentage of fistulae that fail. So his group did a comparative study where they looked at a percutaneous AV fistula creation versus a surgical AV fistula creation. The 6-week maturation, the percutaneous fistulas were better. But other than that, the 1-year primary patency, the 1-year secondary patency, and the 2-year primary patency were not significantly different between the two groups. So maybe, so hence the conclusion that some of these fistulae do mature faster. So faster maturation, secondary patency rates, as well as the surgical AV fistula required more frequent surgical revisions, again pointing to the fact that because of the surgery itself or the trauma during surgery, the vein or the artery does undergo certain changes which can lead to high risk of failure. Wound healing, again, surgical AV fistula, maybe about 1 out of 10 surgeries have some wound healing and infections, compared to less than 1 in 100 patients in a percutaneously created AV fistula. Another comparative study that has looked at a big meta-analysis of the two procedures and included studies from wide variety of centers from all over the world, including a center from India, actually 2 studies from India. And what they tried to do was they tried to look at what were the outcomes of surgically created fistulas along with endovascular AV fistulas, and are they better? Do they have better maturation rates? And they did not show any significant overall differences in the primary patency and the primary maturation rates of these AV fistulas. The infection risk was lower with the endovascular AV fistula, but they did also show the point that I made earlier, that because of the lower flows, the risk of Steele syndrome was significantly better in the percutaneously AV fistula were compared to the surgical AV fistula. So again, this is just the breakdown of those things. Because of the faster maturation, the catheter exposure is much less with the endovascular AV fistula. The rate of thrombectomies is comparable with the total event rate. The number of procedures required to maintain that access was much higher with the surgical AV fistula compared to the endovascular AV fistula. So I told you all the good stuff about the endo AVFs, but there are some challenges. Remember, we said that we are using the deep veins and anastomosing them with the artery. So there can be a preferential anatomy in some patients where the flow is going to go predominantly into the brachial veins. And if that happens, you will have to do some additional procedures to divert the blood from the deep veins into the superficial venous system. There can be challenges with multiple outflow tract. We talked about the maturation rates. If you have a dual outflow tract, like the patient that we saw earlier, your flows in both of those veins would be less. There are challenges in cannulation of those dual tracts. So there are some operators which will routinely create a single outflow tract to prevent those complications. Cannulation of the low flow veins can be a challenge. There is a big learning curve, and we will have to support the nurses to train and get proficient in their ability to intervene in those cases. And then if they do have some complications and they are, let's say they have a thrombosed AV fistula, you will need to have arterial access to be able to intervene in these fistulas. So those are all challenges in these fistulas. Now, as we keep debating whether we want to do a surgical versus a endovascular AV fistula, I would also introduce you to this velocity device. This is a system that is currently under study, devised in the California, United States. What they're taking is the endovascular AV fistula creation to another level, where at the time of endovascular AV fistula creation, after the fistula is created, a stent is deployed from the deep perforator vein into the proximal radial artery. The stent has a certain angle at which the artery and the vein are going to create that anastomosis, and is going to make sure that only a certain amount of flow is going to go into the cephalic vein or into the basilic vein. So studies are undergoing with this new device to try and see if we can get even better in terms of our outcomes with the. So what will it take, sorry for the typo, to establish an endo-AVF program? I think there are several requirements. So the ultrasound skill is probably one of the key requirements. You have to be able to delineate the anatomy of the patient with good pre-op testing. Having a trained sonographer is very important, especially for an ellipsis device where you're doing real-time needle cannulation. And we talk about the nerve block, which really helps in vasodilating the veins at the time of AV fistula creation, because if your needle will hit the wall of the perforator vein, it will go into a big spasm, and then you'll have to use some vasodilators or other stuff. So if you have a good ultrasound technique, that is going to be the key. You may need anesthesia for a regional arm block. Most of the operators who do procedures in the ASCs will do it themselves. You would need endovascular procedures post-creation. Some of them may be arterial interventions. You have to be prepared to deal with some of the complications that can be seen in not most of the patients, but 1 or 2% of the patients will have some hematomas and arterial bleed and may require a stent in the artery to control that. And then cannulation, what I pointed earlier, a very shallow entry approach and utilizing maybe shorter than 1-inch needle for daily cannulation would be the key. So I'm going to end by saying that I think these are fistulas that are viable. They may not be the solution for all the patients, but if you can create a access with less invasive technique for maybe even the third of the patients that may qualify based on their anatomy, I think it's something that helps attain that success with the minimally invasive technique that you have. There would be a learning curve for the interventionalist. Usually it's reported to be about 5 or so cases. After you've done that, you should get very proficient with these. And there's going to be a learning curve for the dialysis unit in terms of when you use these axes. So I'm going to stop here and I'll be happy to take any questions. I'm also going to introduce you to the next meeting that is going to be for the ASDN that's scheduled in the city of New Orleans, known for all the party and good food. The time tells me that there are 209 days left for this meeting. So I welcome you all and invite you all to come and attend that ASDN meeting next year. Thank you, and I'll be happy to take any questions.
Thank you, Dr. Bharat. Before we start with questions, can you go back and don't unshare? Show us the video clipping. It's a very short one once more, so that we can record it in our minds.
I can send the link. It's on YouTube, this clipping, and you should be able to get it on YouTube if you Google endovascular AVF creation.
With your commentary, you start.
Okay, so what you've done is, so let's start it again. So the very first step is going to be where you will enter the vein with a needle under ultrasound, and slowly under ultrasound, making sure that you're not going to hit the wall of the vein as you go from the cephalic vein to the perforator vein. And another requirement is that your perforator vein should be within 1 millimeter of the proximal radial artery. If the distance is too big, then you won't be able to go from the vein into the artery, or there's going to be a big gap between the two. Once your needle is in, I think that's probably the hardest step. After the needle is in, the next step is very straightforward, where you're going to put the wire into the proximal radial artery. Over the wire, a 5 French sheath is going to go, or a 4 French sheath now is going to go into the proximal radial artery. You could see the sheath in the artery over using an ultrasound. You would put the device over the wire into the proximal artery, and the device has this gripping tooth, which is going to hook on to the proximal radial artery as you will pull back the device, and this is where you would engage the artery and the vein wall together. You would apply the thermal energy that causes a fusion and anastomosis between the artery and the vein. You take the sheath out, you take the device out, and you have a fistula that should be functional. Again, the needle entering into the radial artery is the step that would require the most skill to ensure that you have a successful fistula.
Yeah, I think we'll take up questions. Yeah, small thing from me. If 100 patients are willing to take up this procedure, how many of them will qualify for the ultimate procedure?
Studies have shown that it's going to be about 40%, 30 to 40% of the patient may have the right anatomy that would be that they will be eligible. So you have to have the right anatomy, and the key part is the perforator vein. And so I'm just talking about the ellipsis device now. The perforator vein has to be 2 millimeter. It needs to be within 1 millimeter of the radial artery, and you should have a cephalic vein and the basilic vein for outflow. So let's say if you do not have a cephalic vein for outflow, but you have a basilic vein, but then you would undergo that procedure knowing that it'll be a 2-step procedure. You will create a fistula which will have predominant flow to the basilic vein, and then you'll have to transpose that basilic vein for long-term access. But if you have a patent cephalic and a perforator vein with the right proximal radial artery, that should be a good candidate.
Yes, Bharat, you can unshare your thing. Screen. Yeah, is there a way to adjust the length of the anastomosis? Can we manipulate?
So the initial anastomosis is about 2 millimeters, and most of those patients will need a angioplasty at the time of creation with a 3 millimeter balloon or a 4 millimeter balloon, depending upon the size of your proximal perforator vein, to dilate that inflow to that size so that you do not have any problems post.
Okay.
So that angioplasty is done at the time of creation so that you have very little, and even though the anastomosis is without any sutures and it's less than a few minutes old, it does not have any complications. And I think the key part here is that the artery and the veins are so close together and they fuse in. So as you dilate it, the flow will go directly into the vein.
Yeah, can I make a question?
Yes,
Yes, sir.
okay.
I'm Jaraj, can I?
Yes, sir.
Yeah, very interesting. The earlier method that we are seeing is by using two wires, one from the radial artery and another into the cephalic vein from the wrist. And then these two wires have got the electrode at the tip, and they are positioned at the proper place. And then, by radio frequency or some method, these two wires are some current or something passes through that, and that creates a hole. That is the procedure that we have seen earlier. I mean, seen the video.
Right. So the procedure, the device that you are referring to is called the wavelength device. That does require both an arterial and a venous puncture to create that link between the artery and the vein. The artery usually used there is going to be the proximal radial or the proximal ulnar. So that's the advantage of that technique. So let's say if you have a good proximal radial artery, you have a very good proximal ulnar artery, a very good ulnar vein or a radial vein, but you do not have a good perforator. Or if your perforator is far away from the proximal radial artery, in those patients, you can create a wavelength fistula, but not an ellipsis fistula. So there's going to be an anatomy which is going to then dictate which of these two devices you could use for your patients.
Okay, thank
you. I have one, Kashi sir.
Yep. Yes, please.
Sir, I have one question, sir. So I think the critical step looks as it is that cannulating the vein and the artery at that perfect point looks very critical. So say suppose while cannulating, a hematoma is created, or after cannulating the vein, we don't enter the artery and a small hematoma comes. So do we go ahead and complete the procedure, or we abandon because of that layer of blood in between? That anastomosis may not be perfect.
So if your bleeding has separated the vein and artery, let's say you bled from the vein and now there is a big gap between the vein and artery, then obviously you will not be able to proceed with the procedure. So that's why I said, I think the biggest skill set that would be needed is that good, steady hand with a venous cannulation. And that's going to be the learning curve to achieve that degree of comfort with the ultrasound guided vein cannulation.
Yes, sir. So we also have one question in the chat box. Dr. Suraj wants to know that how early can we cannulate the endovascular AVF?
So there are some operators that have cited that as early as 6 weeks, the vein may be, ready to be cannulated. The flow in the fistula should be measured at 2 weeks, 4 weeks, and subsequently 6 to 12 weeks after the AV fistula is created. I think how early is going to be cannulable is going to depend on what is your predominant outflow. So if the predominant outflow from the perforator vein is going only in the cephalic vein, and you've got a 600 plus flow, then you should be able to cannulate that way. Again, the measurement of those flows is key, and they should be done on a routine basis. You should measure the flow in the brachial artery, whatever is the flow in the brachial artery, and you know that your predominant flow is only in the cephalic, will be the flow in the cephalic vein. So you should be able to, as long as you have a flow which is above 600, you should be able to cannulate that axis.
And Bharat, one more thing, when you speak about distance between the perforating vein and the radial artery, is it only the distance or also the alignment of that perforating vein with the radial artery which matters? Because everybody does not have that perforating vein and radial artery in the same alignment. There are angulations of the perforating vein with respect to various people. So would you like to comment on that?
So I think what you're alluding to is the way the vein may dive in and join the deep venous system can be very different anatomy. I think what you need is doesn't matter which way it goes, but as long as you have the artery and the vein within a short distance, you should be able to create that anastomosis. It doesn't matter whether the anastomosis is 1 centimeter from the cephalic vein or lower, the flow will direct in. Now, I think there is a valid question that you raised. Will the anatomy of the perforator vein dictate what patients will have predominantly flow in the superficial system versus the deep venous system? I think that's a question that I've asked as well. And they could be that there are patients with an anatomy that preferentially pushes the flow into the deep venous system and will require coiling of the brachial veins to then divert the flow into the superficial venous system.
So how often is this brachial vein coiling required in ellipsis system?
From the various studies, it's reported to be at least 30 to 60% of the patients may require a brachial vein coiling. And again, it's very dependent on the anatomy of the individual. So not everybody requires it, but then I would say at least half or more.
At least half of it, yeah.
Okay. Now with
the other thing I wanted to add was, when they do these vein mapping as well, you have to look at all the veins and the arteries as well. And if your deeper veins are more dilated than the superficial veins, then there's going to be a problem to mature endovascular AVFs. I think for a trainer like us, we are also trying to get our hands on this ellipsis system. The wavelength takes at least 30 minutes and it's a little bit requires more skill. While the ellipsis, just from the time you get in to create the anastomosis is 7 minutes tops. And I've seen these guys do it. Sometimes you might need like you said, a sonographer to hold the probe while you get your hands free so you can create that initial perforation. But after that, I've seen just the interventional nephrologists do both. So I guess they got very steady hands. So that was the other things I wanted to add.
No, you're right, Adrian. I think the hand-eye coordination is key. And I think when you hold the probe yourself and you drive the needle, you are able to adjust your probe for any angle changes that you are making with your needle. And if you would puncture any vein, and I think that's something that we should practice. Let's say you're doing a AV fistula cannulation, and you can do that under ultrasound to try and improve your skills. So these days, when I puncture the ultrasound, you do it under ultrasound and try and drive your needle under ultrasound with ensuring that you're not hitting the wall of the vein. Your probe needs to stay not in the longitudinal axis, but in the perpendicular axis, the transverse axis. So you're able to see the whole circumference of the vein and ensure that the needle stays in the center of that lumen and it's not going to hit the side wall, which is where you're going to go into a spasm and or risk of perforation or even dissection of that vein.
Yeah, I think that was a great idea, to get used to this. I mean, get as a preparation. Anybody can try this in the dialysis room. There's
Right.
ultrasound guided cannulation.
Right, so you could do it with your dialysis patient, but at least you can, and it's for all your immature AV fistulas that you're cannulating, instead of doing blind cannulations, do it ultrasound guided, and you're able to then ensure that you drive the needle into the vein for at least 1 centimeter or more to ensure that you have that skill set. We
have quite a few strong men in ultrasound here. Dr. Vail, Aravind, and Girish. Girish does a lot of interventions in AV fistula ultrasound guided, and Vail is good at ultrasound, even local infiltration in for AV fistula, etc. And both of you, do you see the prospects of you taking up into this procedure any sooner?
Sir, actually, last time when I was in Atlanta meeting, I was pretty enthusiastic and asked the cost of the device. So maybe Bharat sir and Adrian sir can help me with that. At that point of time, they had told that it was somewhere around 10,000 US dollars. So into Indian currency, it is 8 lakhs as what it stands. But yeah, definitely this looks pretty doable and very easy to execute.
Well, don't say I can easily make a open air fistula, but your thoughts on this?
I hear you, sir. Well, and I will stick on to surgical methods, sir, because we have been 22 years of experience now. So creation of fistula only takes 15 to 20 minutes, and with the sir said 95% success rate. We rarely see failures nowadays, sir. So definitely I'll stick on to only surgery.
No, I think you guys are right that I think the growth in the United States is driven by a delay in access creation that we face in our patient population. My patients sometimes have to wait 3-6 months before they even get into a surgery office. So there is a big need there that needs to be fulfilled. Yeah. I think that is one of the big drivers.
One question.
Reason for this. Yeah.
Yes.
The other thing is, sir, if they can come out with a device, especially if the wavelength can get better and be modified, so that we can create distal fistulas using a wavelength. I think that would be a great innovation and a great tool to have. Because sometimes in few patients, in young patients, we find that the artery and the vein are big enough that you can actually fit in a wavelength. So that would definitely increase the number of distal fistulas.
Yes.
No, you're right. I think, and I've been told that there are some centers that are looking into additional sites of potential, AV fistula creation. The device, the technology for both the thermal and the radio frequency anastomosis is going to be the same. Now it's a question of how else can you apply it in different areas, and including the new change where they are creating the anastomosis with a stent in place. I hope we don't see any increased risk of infections because anytime we leave a hardware, that is the biggest risk. But because you are able to create a precise, controlled anastomosis, your risk of both early failure and late high flow is going to be a lot less.
Sir, one query.
I think
Dr. Prasanna?
Sir, to Bharat sir, actually, thing is like whatever the concept of this is mainly based on the side-to-side anastomosis rather than what surgical anastomosis is basically on end-to-side anastomosis which is done. So as Hemant sir said, actually coiling might help because these are deep perforators. There are always the chance that there are collaterals which are being there in along with these deep perforators. So is there a way wherein at this first step itself, patient might undergo this anastomosis along with it coiling of the perforator, so the distal part, so that the maturation will be earlier rather than the flow being bidirectional, even the distal and the proximal side.
Right, I think that's why ensuring that your flow at the time of anastomosis is not going to be, it's probably going to be about a 200 flow, right? So your flow at 2 weeks is going to be the key in determining where it's going to go in the superficial versus deep. And your point is well taken that these are side-by-side anastomosis. And when you use it in, if you put a stent at that anastomosis, it's going to change it from a end of the vein to the side of the artery. So I think you're right. I think we will have to, kind of keep all of those anatomical changes into account when these fistula are created. But they need a access reassessment within 2 weeks after they created, where you'll check the flow and then look at what the outflow weight is and whether it's going to the superficial or the deep venous system.
Thank you.
I think that idea of the stent that you were saying they were leaving something implantable. Maybe we should move to the next level and switch to a bioabsorbable stent. So we keep it there for a few weeks and then it disappears.
Yes,
so nothing is left behind.
Yeah, but I think one other intent of that stent is the angle at which there is another device that has been studied for surgically created AV fistulas. Where
the weaving, sir. The weaving device? Weaving device?
No, not the weaving. So weaving is something that you can use to cannulate a deep vein. I'm blanking on the name of the device. The intent of the device is the angle at which the radial artery or the brachial artery.
It's the vasque, right, Dr. Bharat?
Yeah, vasque. Yes.
Vasque.
And
there are many.
The intent is that if your angle of anastomosis from the artery to the vein is kept at a 45 to 60 degrees, your risk, the shear stress and the shear forces are less likely to induce neoenthemal hyperplastic generation. And so yeah, that's another intent of that stent in that area.
Dr. Bharat, I have a question, if I can.
Yeah.
So the whole process of puncturing the median cephalic vein all along the perforator up to the radial, the whole thing is done under the short axis view. Is that what you meant, Bharat sir?
Yes, you have to do a cross-sectional view, and then you should drive the vein, the needle into the artery. Once you're in the artery, you can turn your probe and then get into the long axis, so that you can ensure that you're in the artery, you're in the central lumen, and then pass your wire down into the artery.
But till you puncture the artery, it has to be in the short axis view.
Yeah, because if you don't, then your risk of side perforation or side swipe is going to be higher if you're only in the long axis. You won't be able to see the side images. You'll see the anterior, posterior, but you won't see the side wall.
Right. But how easy is that to manipulate the needle under short axis view? Because you're going to pass through three different structures, as I understand.
As I said, I think that's going to be the biggest skill set that you need to master. And then I would encourage you to start using that technique for all your immature AV fistula cannulations that you're doing under ultrasound.
Right. Thank you.
Okay. Thank you, Dr. Bharat. I think this requires a lot more. We can continue in the WhatsApp group or later at the end of the thing. We'll quickly